Hello, everybody. My name is Clayton Fong, the CEO of National Asian Pacific Center on Aging. Welcome to our NAPCA Confronting Obesity panel. We were originally scheduled to be in one of the House buildings, but with the shutdown going on right now, we had to quickly pivot to an all virtual panel. But I think it's going to be a great turnout and a good discussion on a really important issue. Obesity is often viewed as not something relevant to the AANHPI community. So I think we really want to address whether that's a stereotype that is true or not, it's not, and what its impact is in our community. But before we get started, our host, Congresswoman Young Kim, has a message she would like to share with us.
Hello, everyone. I'm Congresswoman Young Kim, and I'm honored to represent California's 40th district, which is located in Southern California. It's a privilege to join you all virtually for the National Asian Pacific Center on Aging panel discussion on confronting obesity. Thank you to NAPCA for your steadfast leadership in raising awareness and advocating for the health and well-being of our elder Asian American community. As someone who deeply values collaboration and community input, I am grateful for your continued engagement. Many older Asian American families call my district home, and I remain committed to ensuring our federal policies reflect the diverse health needs of our communities. During my time in Congress, I made it a priority to expand access to affordable, quality health care for our seniors and the Asian American community. And I introduced the bipartisan Medicare Economic Security Solutions Act to help lower healthcare costs by capping late Medicare enrollment fees. I also introduced the Healthcare Act to help more than 25 million Americans with limited English proficiency better navigate healthcare options. Obesity is a serious and growing health challenge across the nation. And within the Asian American community, certain groups face unique risks. Cultural, genetic, and lifestyle factors all play a role, which underscores the importance of inclusive nutrition education, competence screening, and affordable access to care. Your work makes a real difference, ensuring that every household, every community, and every generation has the resources to live healthier, longer lives. I look forward to continuing to partner with you to build a future where every American can thrive in good health. Thank you again for your dedication and for the opportunity to join you today. I wish you a productive and inspiring discussion.
Congresswoman Kim has been a steadfast advocate for the AANHPI community, and we appreciate her willingness to host us in Congress. But like I said, we're virtual now instead. So let's just, without further ado, go right into introducing our well-balanced and distinguished panels. I think we've got a good perspective. We have three individuals that come from a little bit a different take from what we're doing. We have Dr. Jennifer Ng, who really brings a great clinical perspective on obesity. She's a primary care physician with a specialty and a certification in obesity medicine, and has been a leader on the Obesity Medicine Association, as well as the editor for Obesity Pillars, and was a fellow at Obesity Medicine Association as well. So we're really pleased to have that more clinical approach. We also have a couple of folks that are more in the advocacy, public policy, education, outreach side of it, but a little bit different take. We have Nancy Glick, who has really been had a distinguished career in food and nutrition and education, outreach, and advocacy, not only from the nonprofit side, but also from the I'll call it the PR company side as well. So we're happy to have that perspective. And then Didier Trin is really an interesting perspective from the side of, as CEO of the Diverse Elders Coalition, he really brings a perspective from underserved and marginalized communities and what the impacts are and what do we need to do to make sure no one is left behind with regard to all of this. So with without further ado, I'd like to just begin with a couple of questions each. I do want to say that if you have a question that you would like to ask, put it into the chat, and we'll do 2 or 3 to kind of prime the pump, and then we'll get to the actual questions from the audience afterwards. Each panelist, I'll direct the question to one, but feel free to chime in on that question as well. So let me start with kind of a broader question for Dr. Ng. In the AANHPI community, are we underdiagnosed? And what does that mean for our community? If people all think we're thin and have good diets and health, what is the impact in our community? What's the truth and what is the impact?
Well, first of all, I wanted to thank you all for having me here today. And yes, unfortunately, as you said, we are underdiagnosed in the AANHPI community. So, for diagnosis, just kind of as a background, we use the BMI criteria, the body mass index, which is a calculation of your, based on your weight according to your height. And that gives us different values, and 25 to 29 is considered overweight, and 30 and above is considered obesity. And so unfortunately, this criteria was first developed a long time ago, and it was based on data actually from a non-Hispanic white population. And more recent data has shown that actually the AANHPI community actually has different risk, has a more risk at a lower body mass index criteria. And, when they compared the populations, they saw that this community, as compared to non-Hispanic white population, has a higher body fat percentage, also increased risk of diabetes and cardiovascular disease at the same BMI as someone who is a non-Hispanic white person. And so, so this is something, unfortunately, that has, kind of perpetuated in both the general public and also among the medical community. And so the WHO and the ADA have both actually recommended to use lower BMI cutoffs for the AANHPI community so that we don't miss diagnosing and screening in this group. So the BMI cutoff is recommended to be 23 instead of 25 in the general population. Okay. And some of the reasoning behind this increased risk at a lower body mass index is because the AANHPI community actually has an increased propensity for visceral adiposity, which means increased fat around or in and around the organs, which of course interferes with the functioning of the organs, and that leads to conditions such as metabolic syndrome, insulin resistance, diabetes. And so it's important that we screen appropriately so that we can both counsel our patients accordingly, make sure that they take preventive measures if they are at increased risk, and also if they already have these conditions, that we treat them, that we don't miss treating this population. Because when we miss these diagnoses and prevention early, then people end up presenting at a later stage, with, for example, with significant complications from diabetes. And of course, that is more costly to treat the later the stage of the disease that is diagnosed. And, the other thing is, so first, of course, making sure that the medical community is aware about this. And also, second is making sure patients are aware, right? So I have a lot of patients who have come in who are of AANHPI background, and they have said, "Oh, I don't understand. How can I have fatty liver? I'm so thin." And then there's a lot of counseling on my part to help them understand that this is a different, for this community, there is different cutoffs and different, risks associated with the lower body mass index. And there's actually been a move recently to actually use other measures besides the body mass index in, diagnosing and screening patients. The recommendation is also to use things like waist circumference, body composition testing, but waist circumference is the most easily accessible among the population because it can just be done with a tape measure in the healthcare provider's office. And so I think the important takeaway is that we need to make sure that this criteria is well known, that the BMI of 23 and above should be used in the AANHPI community for screening, so that we can make diagnosis and also take preventative measures early, and also that the patients should understand that this is, that they're at a different risk, compared to the general population.
Thank you. There's no doubt that while based on BMI index, we might have lower incidence, but it is absolutely a fact that diabetes-related illnesses are much more prevalent in our community. I can speak personally. Absolutely. I was diagnosed late with type 2 diabetes, and when you're late, it's harder to reverse. So I think that's a very important conversation. The other important point to make, besides the fact that as a whole we're underdiagnosed, but there are big differences within our communities. So for example, in the Native Hawaiian Pacific Island communities, the South Asian communities, and in the Filipino communities, there are higher incidents of obesity and obesity-related illnesses. So we appreciate that perspective. Maybe would any of the panelists want to comment on that broader subject of underdiagnosis?
Yeah, I would be happy to. It's sort of part of my my spiel, which I'll probably get into more detail, but the entire country is underdiagnosed for different reasons. And it's a sad fact that that's the case. But, if you consider that there are 100 million adult Americans with obesity, the statistics of how many are actually being diagnosed, counseled, and treated is very low. Maybe about 20%. So we have a lot of work to do. And part of it is, of course, having the flexibility to be able to diagnose people based on their body composition and their ethnic background. So it all is one piece, but suffice it to say that, as a disease, obesity is largely discounted and underdiagnosed and undertreated, and it is a national problem.
There is no doubt obesity is an epidemic in this country, but AANHPI community is no exception to that rule.
Absolutely.
Clayton, if I
Didier,
can
would you like to comment?
Absolutely, and I'd just like to piggyback on what you mentioned earlier, Clayton, which is the lack of disaggregated data across AANHPI communities. For example, Filipino, Japanese, and Asian Indian adults have a greater prevalence of obesity than Chinese and Vietnamese peers. And recent studies suggest that the need for disaggregated data within the AANHPI community will actually lead to greater investment in treating obesity and obesity-related comorbidities in those communities. And coming back to where you started this conversation, when we lump together everyone as Asian or AANHPI, we actually miss which communities are hurting the most.
All right. Well, I would say that there is no doubt that we need to focus more on this, and there is definitely a misconception with regard to, and I've often, it may sound a little bit trite, but our community isn't all Westinghouse science winners, Harvard grads, rich and thin. It's just not the truth. there are great needs and there are different. So just healthcare really needs to be person-centered, not broad-based. And so anyway, Dr. Ng, before I shift a little bit to policy, is there anything you would like to kind of add on to the clinical side of this discussion?
Yeah, I agree with everything that has already been said, that it is important to individualize treatment, for each patient based on, many factors, their genetic backgrounds, their ethnic backgrounds, and I think that, unfortunately, there is a lot of weight stigma, both among the healthcare community and among, patients in general. A lot of either that it's dismissed, that it's not considered a real healthcare condition, or, or that people, feel, oh, it's something that if they just worked harder with their diet and exercise, they'll get better. And if they didn't get better, it's because they didn't work hard enough. But we know that's not true, because people can work really hard. And I have, plenty of patients telling me, in their office, crying in my office, that, that they've tried so hard and they don't understand why nothing is changing. And that's why there's medications. And actually, the recent data has shown that the obesity rates in the US have stabilized to even kind of maybe starting to decline slightly. And that's since the advent of these highly effective medications, which we'll get more into, but of course, not everyone has access. And, even with access, a lot of the AANHPI community are kind of left out a little bit because the criteria for diagnosis is not the criteria that that we should be using, because they should be diagnosed at a, or they should be screened and diagnosed at a lower lower BMI and waist circumference cutoffs, as we mentioned, as I mentioned before. So
that's a good point. On an individualized basis, I'll just use the blunt word. Fat shaming has an impact on whether people are going to self-diagnose or be diagnosed. I want to, so along with, if we're underdiagnosing or we're not, or we're stereotyping folks not to be obese, or if the criteria is too high, what is the public policy impact of access to education, outreach, medications, treatments, and what have you? So Nancy, maybe you can talk about it from the broader side, and then maybe Didier can talk about it from the community specific side.
Well, I'm delighted to. So for those who don't know me, I'm the Director of Food Nutrition Policy at the National Consumers League. And the National Consumers League is the oldest national consumer organization. We date back to 1899. And we have been working to improve the health of Americans since then. And as I said before, there are over 100 million adult Americans with obesity. We looked at this issue from a consumer lens and recognized that the problems that we face today are all basically what I would call human obstacles, more or less what was said before. We have terrible stigma about this disease, and it is a distinct disease classified as such by the AMA back in 2013, and it's taken us this long to get to the point where enough Americans understand it's a disease. Weight stigma is incredible among health professionals and policymakers. You can go into congressional offices and still hear people talk about, well, why don't we just get people to eat better and exercise more? And we should get people to eat better and exercise more, but that's not going to stop the epidemic of obesity. We also learned that because of these, what I call human obstacles, the entire healthcare system really is not prepared to really understand and treat this disease. And we have been screaming from the rooftops about it because obesity is as serious as cancer, diabetes, heart disease, hypertension, sleep apnea, you name it, all of which are directly related to obesity. In fact, 230 plus chronic diseases are made worse by the disease of obesity. So until policymakers understand we will not solve the problem of chronic disease in this country until we learn to treat people with obesity with the parity that they get as they have diabetes, cardiovascular disease, et cetera, we will fail. So in 2024, the National Consumers League and the National Council on Aging issued the first obesity Bill of Rights for the nation. 8 rights. And what we are saying is that every American has the right to be treated for their obesity, which of course includes Asian Americans and Pacific Islanders. And that starts with understanding what obesity is, having qualified physicians, ending weight state stigma, which to me means we need to literally make it uncomfortable for people to discriminate against people with obesity, and that may include legislation. We talk about the whole idea of personalized medicine, and certainly that is appropriate to this conversation. We address issues such as what happens when you have very large people who don't fit into chairs, don't have the ability to go into one of these imaging systems. We need to be able to understand how to treat those people with respect. And at the end of the day, one of the most important of our rights is the right to access and coverage for care as specified by medical treatment guidelines. This is the cross current of why we are not getting further. Because if we have good doctors who are able to identify, screen, diagnose, and provide a prescription for a GLP-1 drug, and we do not have a healthcare system that is going to cover it, we have failed. We have not gotten where we needed to go. So the obesity community writ large is united in the fact that we really need to demand that there be coverage for anti-obesity medicines and all other appropriate treatments. And that includes these new GLP-1 drugs, which are safe and effective and are frankly game changers because they do work and they achieve what's really clinically significant weight loss. People's lives have been changed by these drugs. So our challenge really now is the idea of how do we encourage payers to think beyond the dollars and cents of short-term budgets. And this is a discouraging situation, particularly now, as pretty much we did an analysis recently, and we had made great gains in terms of commercial insurers, state plans, for retirees and employees, et cetera. Medicaid was starting to cover GLP-1s, and government programs like Veterans Administration and TRICARE for military. This was all happening. And then, of course, we have now gotten into this situation where, we are, the big, beautiful bill has sort of forced more of the costs of care to be borne by states. And so everybody is having to go back and rethink their budgets. And there has been a significant drop in coverage across every health sector, which is, going to be taking us backwards. We're very concerned about this. We've been arguing a lot on the Hill about the fact that new data, because these are new drugs, so it takes a while to, sort of get data on how well they're working. But new data shows now that the treatment of obesity, which may cost insurers some money, actually reduces the overall healthcare expenditures for the person. So if you look beyond a silo of what does it cost to treat a person with these drugs and looks at how they are doing in terms of their healthcare, it is pretty significant data. There's also a very exciting new thing that happened. There's this group called ICER, the Institute for Clinical Effectiveness Research. We don't normally love ICER because they look at new drugs and they tend to think that nothing is clinically effective. They gave the highest rating to these new GLP-1 drugs as effective treatments, more so than diet and exercise. So we do have data now that we can go to Congress and we can say it's time that Medicare cover GLP-1s, that Medicaid cover GLP-1s, that we reverse this decline across the government payers and commercial payers. I will tell you something new that happened today that may sort of, well, it's an exciting new development. So just before we started this Zoom meeting, the White House announced that it had reached an agreement with the two manufacturers of the GLP-1 drugs to significantly drop the price for Medicare starting in 2020, the end of 2026, I believe. And it will, first of all, the fact that they have negotiated a price for Medicare means that we may, in fact, get Medicare coverage next year, which, oh my gosh, we should all just, go out and start having a celebration just about that. But it would also, I think, then set a new standard for us to be able to, get commercial insurers and others to, again, expand their coverage. So this is very exciting news for us. And hopefully it is the beginning of something better. But even then, we have to continue to be advocates, not only for coverage, but, for making sure that our medical system, our healthcare system, recognizes obesity as a distinct disease, recognizes that all bodies are different, and that we're going to need to have personalized approaches with qualified, well-trained medical professionals.
Thank you, Nancy. And Didier, I don't know if you want to comment on this angle of it. Well, first of all, I understand that price announcement, it may be cutting the price in half, which would be a pretty dramatic change for everybody, and and a broad access to it. But here's an interesting question, Didier. On a public policy side, from a health disparity side, if we're underdiagnosed, how is that coverage going to come about? And is it connected to BMI, for example? And if Asian Americans have to have a 30 BMI to have access to this, that we may have almost nobody having access to it. So what do we need to be aware of as we look forward on a more community perspective?
I think one social driver of obesity I'd like to touch on that might seem obvious but could easily be overlooked is just the broader food insecurity for AANHPI communities, in particular older adults. Food security is rising among AANHPI older adults, in particular among Vietnamese and Chinese American older adults, which suggests that being foreign born and speaking a language other than English at home can be linked to that food insecurity, which is why we need to be focusing on the need for tailored food assistance and meal programs that accommodate cultural preferences and in particular different languages. As NAPCA knows full well, language access is foundational in helping to improve obesity rates among AANHPI communities. Over 1 in 4 AANHPI adults are limited English proficient, with even higher rates outside of the mainstream Asian languages, which is why we need to invest in interpreters, for example, that cover languages outside of the sort of more well-known Asian languages. And without language access and without those supports, AANHPI older adults have really no clear way to access health information and to actually take advantage of interventions that may help them reduce obesity.
Dr. Ng, would you like to comment on this? Because I think it's you have a very interesting perspective as a clinician. What is covered? Well, this could be exciting because Medicare might cover it, but at what level do they cover it? An example I would draw, some plans, a very small number, might cover acupuncture, right? But they cover it for such a narrow range, it's almost is the coverage there. So here's the question is, if one, are plans going to cover GLP-1s or other treatments? And even if they do, what's your experience on how narrowly they cover that? And then do people end up having to pay out of pocket?
Yeah, so there are some insurance, commercial insurance plans that cover the GLP-1 medications, and in my experience, it has been usually for a body mass index of 27 with complications from obesity or overweight, and or just a body mass index of 30 and above, with or without any kind of complications. And I am not sure if, with this lower prices that are negotiated for Medicare, if that's the criteria that they will also use. But as I mentioned, they would miss a bunch of people within the AANHPI community that that they're at increased risk, even at a BMI of 23 and above. And so I hope that is something that the policymakers are going to consider. I think that's very important. And I just also want to echo on what Nancy had said earlier about there being a lot of stigma and that people should that there's a belief that people should just work on their diet and exercise. So when I treat patients who actually have access to GLP-1 medications, they have told me that it is life-changing and that its impact on their behavior, that they eat better, they make better choices because the medication helps them with that. And so it's a reinforcing, kind of loop where you go on a medication and you're less hungry, you have less cravings, you have less food noise, which is something patients have told me over and over again. They don't even realize they have this food noise until they stop having the food noise. And then because they no longer have, the food noise, there's less cravings, there's less hunger overall, then they can make better choices with their food, options, whether they're at a grocery store or at a, restaurant. And also now, there is, they have improvements in their weight. They no longer have as many joint issues or joint pain, and then they can do more exercise. So it is going on these medications helps to reinforce the diet and the exercise and the behavioral change. And I don't know if, enough people recognize this, so certainly I do. My patients can see it, and, and I see it that the more, the that everyone who goes on these medications end up actually having better like diet lifestyle changes. And I think that's a very important piece. It's everything works together, and it's made better like together.
But those are good points. I want to say to the audience, if you have a question that you would like to submit to the panel, please feel free to submit it to the chat. You started to bring up an interesting question around when we talk about language and culture and what have you. We work a lot with Asian American elders who, when you talk about lifestyles, I mean, diet is clearly one of them. Where do we go to be aware of how to change diets, but within the context of the food that you like to eat, the recipes you like, would anyone like to comment on kind of the cultural competency issue of understanding who they are, where they play, where they eat, what they like to eat, and providing education, outreach, and interventions within the context of who they are?
Well, I could say that as part of our Bill of Rights, we sort of looked across what you would call the treatment continuum, starting with, the diagnosis, et cetera. We also support this idea of BMI just being a screen, because it really takes more a weight to circumference measure or other things to really understand. But one of the things that when you are getting into personalized medicines, it's not just here's a drug to take, but it's the whole concept of, the medicine and your lifestyle. So one of the things that hopefully will happen with Medicare would be not only to have access to these medicines, but to what they call IBT, which is intensive behavioral therapy. And what that is having a nutritionist or some qualified professional who literally helps you think through, based on how how old you are, what your circumstances are, how you adapt your diet, physical activity that you can do, your community activities, etc. So it really is a whole person kind of approach, because these GLP-1 drugs are not meant to be a magic bullet. They have to be done as part of a behavioral modification system. And so it really is a combination of things that people will need. And I know that if you look at diabetes, for example, where there's been a lot of experience in this, there's been a lot of information about how to make healthier meals, how you can substitute ingredients. And the whole idea is not to tell people that they can't eat things. We don't want to make people miserable. So it's just sort of how you can live healthier. And, if you've got a patient who is doing well because of these drugs and other things, they're more, I would say, open-minded to, thinking about ways to adapt their menus, et cetera.
I just wanted to jump in and say, so as Clayton mentioned, I am associate editor for this journal, Obesity Pillars, and we actually have articles in the Obesity Pillars that talk about this very issue, about how do we, kind of provide obesity care that is more culturally sensitive. And there are actually several articles from what I remember, one that I am co-author on about East Asian, treating patients of East Asian descent, and how do you manage those patients and also obesity, and what do you do about their diet, and how do we approach this in a culturally sensitive way. And there's also another article, I think, for the South Asian population. So if anyone is interested in those kind of resources, then I think Obesity Pillars is a good place to look for them. And I'm sure there's other journals that also have, this kind of information provided by clinicians who work with these populations.
And if I could just mention a policy perspective based on what Nancy was describing. There is bipartisan legislation in Congress called the Treat and Reduce Obesity Act, which would basically expand the types of healthcare providers that would facilitate that intensive behavioral therapy for obesity that Nancy was speaking about.
Yeah, I'll speak personally as a type 2 diabetic. It was hard in the beginning. I missed my big bowl of rice at every meal, and I ended up substituting tofu for my rice. But my wife actually started making brown rice, which I didn't like. So we started off with kind of half and half, and a smaller portion, and it worked better. Then ultimately, then she found out that, and maybe this isn't so good, but she found out that if we fried the brown rice is firmer, so it actually works really well as fried rice. And it was just a way, from a personal side, my numbers dropped because that was kind of the placebo it works. And that's it's kind of getting to know a patient from where they are and what makes them tick. It's not, and that's, whether it be obesity or whether it be, high sodium diets that are very common in our Asian recipes, and how do you do things to kind of cover those pieces. So it'll be interesting, and it'd be if anyone has any ideas of where you find some of those recipes, I think we may have to embark upon that on our website. Maybe people submit their favorite healthier recipes for Asian food. Anyway, what I want to do, we only have about 14 minutes left to go. Do we? Questions?
Not any questions.
Okay. So, what I'm going to do is call a little bit of an audible, and, I'll ask our panelists, is there something you feel like we've missed? Because I maybe didn't ask all the right questions. Maybe go in reverse order. Didier, do you want to start? And then Nancy, and then Dr. Ng.
I would just come back to what I was suggesting earlier around and where we just left the conversation, which is thinking of policy solutions that better leverage home delivered meals that are tailored to AANHPI cuisines. I think about my Vietnamese grandmother, although this wasn't obesity related. At the age of 96, she had to be transitioned to a nursing facility where she was basically forced to eat non-Vietnamese food that she was completely unfamiliar with. She had cooked her own meals every day of her life up until the day she left her home. And so it required the rest of our family to try and deliver Vietnamese food to her at the nursing facility, because she just didn't take to the American food that was being provided there. And I certainly believe that it contributed to her passing. She wasn't in the facility for longer than a month before she passed away. And so I just think more broadly, we should be striving to take into account those cultural considerations on top of obviously providing services around language.
Well, that's a good point, Didier. And I want to say that, sometimes the RDA requirements around congregate and home delivered meals often aren't updated to reflect kind of cultural diversity. And I would make this comment: it's very meat and potatoes oriented in its old fashioned way. But how do I put this? But baby boomers in general who will be needing these services soon, like to eat a different food every day. And so it isn't really just for our community, it's for everybody to be more diverse culturally and have more variety. So anyway, Nancy, please.
Yeah, I would say on that subject that, this whole idea of food as medicine is getting a lot of acceptance now in Congress because yes, it is, it's the fuel, it's what we need. I certainly agree that, it's terrible what happened to your grandmother because we really need to understand that, there needs to be some joy in your life, and food is part of that. One of the things I would like to bring up, it is a bit of a pet peeve of the National Consumers League, and it has to do with the unintended consequence of not having coverage for GLP-1s. And it definitely affects communities of color, women of color. And that is this issue of the online, unregulated, exploitative market that now exists that is promoting untested, unapproved, compounded GLP-1 drugs, fakes, and counterfeits. And we are exceedingly concerned about this because there is a significant risk for harm from consumers going online for reasons that I will not go into. Compounded drugs are regulated differently. They are basically not held to the same standards as the FDA approved drugs because they are not meant to be sold on a continual basis. It's sort of during just a shortage period. And so what we've ended up with is massive disinformation because marketers are not required to disclose the risks. And so people have a sense that they are in fact taking sort of a generic version of a drug. It is not generic. Generic drugs are approved by the FDA and they use the same ingredients. Compounded drugs are different with different ingredients. And the problem is that these different ingredients involve the body getting different dosage levels. And so there have been situations where people have inadvertently taken 20 times the dose because they don't know. And so you've got a collision here of lack of information, which Didion was talking about. We have to make sure that Americans have the true facts about these drugs, how to use them, what the risks are. And that's not happening right now. And then you have this pervasive fraud. So we have been very public about the fact that all of us should really raise alarm bells about the fact that this exists, encourage people to talk to their doctors before they go and buy some of these things that they think are the same ingredients. They are FDA approved, they are not. And it's a very, very serious issue. And we've been talking a lot to Congress about this because if we can't get them to understand that obesity is serious, maybe the fraud associated with people basically being able to buy things that are untested and unapproved will get their attention. So I just want to bring that up for everyone. We have a website called The Weight Truth, and it actually shows people what counterfeits look like, what fakes exist right now, and a new thing that is very concerning to us, which is what is called microdosing. And that's where we are encouraging young girls to get smaller doses of GLP-1s to prevent obesity. This is dangerous. It's never been tested, and we should not be encouraging young girls to go online and do this. So, SOS.
Maybe we can have Dr. Ng comment on that and anything else that you think we missed. But certainly from a clinical side, that would be an important thing to be aware of, these kind of online access points.
Yes, unfortunately, there are, I'm well aware about the compounded medications problem. And, unfortunately, the reality is that people are desperate to take these medications and they will take them any way that they can get them, right? So if they can't get them, the actual medications from the manufacturers because of lack of insurance coverage or, or really, high copays, and they can't afford it to pay out of pocket or to pay the high copays, and they will turn to the compounded medications, and we are seeing cases of people being hospitalized, for taking compounded medications because dosing errors, as Nancy had said, and also because the medications are often compounded with substances that they weren't studied to be compounded with. Sometimes I hear patients say, "Oh, I'm taking semaglutide with B12," and I'm like, "Oh, okay." And they, and I, of course, try to discourage them from using these regulated or not so well regulated, compounded medications. But it's the desperation, right? It's and we need to help patients, not to force them to turn to like these people who are making these compounded medications maybe to profit, and not really to help patients. And so that is a big issue. And then there's of course also the whole body dysmorphia that Nancy mentioned, that people are being targeted, that you should take these medications so that you can lose weight to look better. And that is, also a very big issue among patients now, which ties back to the stigma. And, the message here should be not that you need to lose weight, but that we need to improve our health. And so, when we talk about losing weight, we're really talking about trying to reduce the amount of body fat, not just to solely lose weight, which is unfortunately how the message has gotten out. So I think we need to, make sure that people understand that, the benefit is here in the reduction in body fat, and the reduction in mainly the body fat that is in the organs, that it's the visceral fat that I had mentioned earlier in this conversation here, and which is one of the things that the AANHPI community is higher in, the visceral fat. And the target is to improve that, not to just solely lose weight, even though we talk about it as a weight management, weight loss medications. It's really it's anti-obesity medications. And then finally, to echo back to Didier, we need better, education on how to provide like culturally sensitive kind of guidance to people. And the good thing is there is more kind of recognition that this is needed. And actually, I am on faculty at at one of the medical schools, and there's actually a lot of interest now in in culinary medicine, which is basically it's a newer kind of field in medicine in which we're trying to adopt the food as medicine idea, and use that to help our patients, so that we're teaching our medical students better nutrition, how to understand food, and how to make food choices, how to help patients like with healthier food recipes that are also culturally sensitive. And that's something we're starting to do to educate the next generation of healthcare providers on how to guide our patients on nutrition and culturally sensitive food choices. And so I'm very excited about that. And hopefully, we also can do better, also public health nutrition guidance, to help everybody in the population, because that is important whether you're on medications or you're not on medications for your health. So.
Thank you, Dr. Ng, and we're almost at the end of our time. So let me just try to do a quick summary and say, you know, there's no doubt there's a obesity epidemic, and there's no doubt now that the AANHPI community is no exception to that rule. But we also want to talk a little bit about the fact that intervention should be person-centered and culturally and linguistically competent. But there are also safety issues around GLP-1s. We're pleased that announcement of GLP-1 coverage may be coming from Medicare and that the price may be dropping. I would also just say that this is a distinguished panel that has a lot of presentations on the subject matters we just talked about. So I would encourage you to follow them, look them up, and find some of the other interesting things that they've talked about, whether it be around obesity, cultural competency, access, food and nutrition. Maybe we're beginning to change, but our health systems are probably a little interventionalist rather than preventionist. And maybe as we talk about things like culinary medicine and food as medicine, and access to things like GLP-1s is a little bit more of a holistic prevention approach rather than intervening after we are sick or what have you. So with that, I want to thank each of our distinguished panelists for your contribution to this conversation. And I will apologize to the group. This was supposed to be in person, and we pivoted at the last minute to go virtual because we couldn't access the Capitol. But and we want to thank Congresswoman Young Kim for hosting us, and we will certainly get that video up the right way. Thank you again on behalf of NAPCA. We appreciate your time, your attendance, and your attention to this matter.